thinness does not define your happiness. You think it does until you get there. That's what, the Hildebruch expression of thin fat. She said, and I love this, she said, people who assume that becoming fat is going to take care of their discomfort, their dissatisfaction in life, find out that weight loss has not done for them what they hoped it would. So I think communicating that weight loss is just about weight loss, which can be important, but it will not solve all your life problems.
Today, we're joined by Mary Anne Cohen, a psychotherapist who has been working in the field of eating disorders for over 5 decades. And she's the founder of the New York Center for Eating Disorders and someone who has spent her life helping people understand the deeper emotional roots of their relationship with food. Mary Anne is the author of 4 books on emotional eating, including French Toast for Breakfast, Declaring Peace with Emotional Eating, and more recently, Ozempic for Smarties, A Psychotherapist Tells the Straight Skinny, which explores the complexities of GLP-1 medications through a psychological lens. Her work has long centered on the idea that our struggles with food aren't about willpower. They're about our emotional lives, our histories, and our relationship with ourselves. Welcome, Mary Anne.
Thank you. Thank you.
Mary Anne, I'm particularly excited to be talking with you today. I've been following you for a long time. I'm a fan back from French Toast for Breakfast, which was, I think, your first book back in the 90s. I'm so curious to know, I think I almost know the answer, but I'd love to hear from you. What motivated you to write your newest book, Ozempic for Smarties?
Well, first of all, you were the catalyst.
How so?
So I attribute that book to you because you had written me an email and you said, how could you, an eating disorder therapist, in any way sanction this? And I had a couple of experiences that led me to conclude that this is not black and white. It's nuanced, it's shades of gray. And your question actually moved me to want to explore for myself. And, we write what we want to explore. So I've done a lot of reading and gone to a lot of webinars and have a lot of opinions. But I have to say, I had 2 experiences that really made me pause. And by the way, I was very skeptical. I mean, Meridia didn't work. I don't believe in Vyvanse, which is the first medication for binge eating disorder, which makes people manic and crazy. They lose weight, but they never sleep. And Orlistat, all of these weight loss medications were not adequate. And so I was skeptical. Then my most difficult patient, who has been bulimic for 35 years, has been in multiple hospitalizations, multiple therapists, multiple medications.
Very, very common, very common.
She couldn't hold on to recovery. She went to Renfrew. She's been Westchester since the age of 15. And she said to me, my scariest patient, she said to me, I feel like if I could just try this medication and it takes away my urge to binge, maybe I won't need to purge. She was throwing up multiple times a day. She refused to go back to the hospital. I couldn't twist her arm. And I said, okay, let's give it a shot. And I hooked her up with the nurse practitioner. 12 hours after having her first Ozempic injection, the urge to binge and purge died down.
Well, this is the nuance, isn't it, right? I mean, when I wrote to you, by the way, which we should say was now several years ago, I think we were all in the state of evolution about this, right? There is no black and white.
And boy, has it been an evolution.
Yeah, it really has been. You know, we always say on the podcast that body autonomy rules all, right? So people get to choose whatever they want. They're not going to get any judgment from us, right? And I think we're all trying to figure out, how do you integrate this if that's what someone's choosing? It doesn't mean we're going to recommend it, but it's going to be integrated. And I'm assuming that's one of the premises of the book.
And I just
Yeah.
want to say that I think at this point in time, as we talk about the evolution of how the GLP-1s have come into our culture, they've come into our practice,
Mhm.
right? If we're working with women and men who are really struggling with their relationship with their food and body, and in the beginning, I felt like, uh-oh, here we go again. And now I'm watching people navigate it in so many different ways. Some really elegantly, like, wow, and some like, oof, and they're like, I'm out. Some they're on, they're off, they're on, they're off. It's created a whole other, you know, chaos for them.
Right.
And so I'm wondering, I also want to talk about, like you've sort of talked about the miracle of it. Do you have concerns, and what are they?
Of course. First of all, I don't think this medication is for everybody. It's certainly not for an anorexic who can never get thin enough. I think these medications can be dangerous. And I think that nobody should be on them without certain guardrails, which we may never achieve with our inbox being full of, today it came out that you can start getting it for $15 a month. So we're being drowned out by the commercialization of it.
Yes.
But that does not
Oof,
mean,
wait, hold on. That's such an important statement
yeah,
that you just made, and I really want to reiterate
Mhm.
it. We are being drowned out by the commercialization of it,
Mhm.
right? The impact of the marketing, the impact of the pressure is drowning out our individual voices, right? And we all know from working with people for decades that we need our clients to be leading. Their voice needs to be heard. It's, their disorders are part of what makes them invisible. And so now we've got this huge marketing machine squashing the individual path. So sorry, I interrupted because it was so important to name that.
and I want to say that advertising and commercialization makes it look like you want to lose weight, take an injection, and you're good to go.
Mhm.
I would really recommend that anyone considering it or going on it have certain guardrails. And my guardrails are, you have to be in therapy. And I'd love to talk a little bit more about why I feel that way so strongly. You have to be with a medical provider who knows what they're doing. This is new. A lot of medical providers do not know, and that scares me.
Well, I want to interrupt you for 1 second there, because I think you're making brilliant points. We can barely track them. They're so important. Medical
Curious.
providers. We live in a world of diet culture.
Yep.
And the medical profession, God bless them all, they mean well. Many don't even know what they don't know, and they don't even realize that they are imparting their own stigma and their own diet culture all the time. And often they will be the ones to suggest GLP-1 before a patient even comes to them and says, gee, I'm thinking about this. What do you think? And so the message that gets delivered to the patient is, well, everything else would be okay if you would just lose weight. So that's not the informed provider. The informed providers are hard to come by, and I know that we all work very hard to help them become more informed. So I'm wondering if you agree that it's challenging to work with medical providers that really do get this.
I really do, because look, medical providers are part of our culture. They have the same fat stigma internalized in them
Yes.
that we
Mhm.
as a culture do.
Yes. So you said you wanted to say more about the fact that being in therapy while on the medications is an essential guardrail. Can you say more about that?
Yes, I would love to. But let me add the other guardrails outside of therapy and a good medical provider have to be a nutritionist.
Mhm. Mm.
And that should be the three prong approach.
Right. You should be held. You should be held. You're going into a serious process by stepping into the land of GLP-1 medications. You should be held well. You should be supported well. You should have those. So you said therapist, nutritionist. What was the third
Medical.
one?
A good medical provider.
A good medical provider.
Right.
Yeah, no wonder I forgot that one. I haven't come across them. So,
Mary Anne, you make a brilliant point here, and I don't want to let it go by. The team approach is the way to do this, and it's so
Absolutely,
hard
yes.
to, first of all, make providers understand this, but also sometimes clients, because sometimes, there are financial factors or whatever it may be, but that team approach is really the way to do this. So please say more about the other guardrails. Yeah.
Yeah. I think that if it's not done in a team approach, really playing with fire.
Mhm.
We know that these medications can seduce people into worsening an eating disorder
Yes.
or maybe even developing an eating disorder
Mhm.
because the seduction of let's get thin, let's get thinner, let's get thinnest. And I've heard some horrible stories, by the way, which maybe I'll share with you because
Before you do that, you're known for certainly integrating and coining a phrase called emotional eating, right?
right, right,
So I'm wondering what you think about this phrase called food noise,
okay.
because this is really what people come to us with now. It's in the zeitgeist. They talk about it and they say, "I have food noise. I need to get rid of it." So I want to go on the GLP ones. Not that they're looking for our blessing, by the way, but this is what they're coming in to say. I want to be on this. What do you think?
I think a lot of colleagues in this field have concluded that food noise is because people are restricting and the noise in their head is beckoning them to eat because they really haven't allowed themselves to get full. And so the constant reverberation in the head is I need more food, I need more food. I think that's only part of the problem. And the other part, I think, is not taken into account, which is a lot of my patients have food noise because they're diverting or distracting or detouring themselves from another problem that they can't, they won't face.
Mhm.
And therefore, I believe in the psychoeducational approach also of letting people know that emotions may be driving your food noise. And here's how I determine it. I say to practically everyone who's interested in taking this medication, if we get your food noise to be quiet, what is the next issue that comes up for you?
Mm. Mhm.
So I'm inviting them to
Right.
possibly identify what the food noise may have been covering up. And it's been fascinating. One woman said to me, and it was like she blurted out, divorcing my husband. And then she laughed and she said, the truth is, his drinking is driving me crazy. And when I'm binging, I'm not thinking about it. So this is important because people without their food, which we know is a coping device, need to understand that emotions that have not been digested may come up. I had one girl, a young woman, say to me, I've thought long and hard of wanting to get rid of my food noise. And the next issue up for me is my grandfather's sexual abuse when I was a kid.
You're touching on something that's critical here, right? So often when people are using food, let's say, to other than to feed themselves as a device to numb out, there is trauma. I would say safely in the 25 years that I'm doing this, that trauma accounts for 80% of the cases that I work with. And that's
yeah.
just
Right?
reported. It could be 100 for all I know. Yeah.
Yeah. And what made this girl special to me is she said, I know the next issue is I have to deal with this abuse by my grandfather. And she said, I'm not ready. And I'm not going to go on the medication, not because I don't want relief, but because I know it's going to come up. I'm not
Yeah.
ready. This was so
But
beautiful.
Mary Anne, it really speaks to this issue of people do go on the medication, they lose weight, and they're still not feeling at home. Still not feeling at peace. They're still struggling. Why? And it's exactly what you just said. There's underlying issues that a medication can't put a mute button on. It can mute the I'm hungry moment,
Right.
but it doesn't mute everything underneath.
Exactly. And, you know, Hilda Baruch, who's the pioneer in the 1950s of eating disorders, she coined the term thin fat, that people who get thin but consider themselves still fat because they have not, how should we say it? They have not,
They haven't integrated.
yeah, exactly. They have not integrated the need to feel fat and whatever that's about for them.
I think the thing I want to just put out there is that, you know, one's perception of their own body in the world is affected by so many things. And I think the idea is if I go on this drug and I can stop myself from myself and I can lose weight and I can actually be able to leave food on the plate. This is what I hear is like the big goal. It would be great for me to see that I can leave food on the plate. Okay, that's some marker for some people. And if I can just do all of that, then I'll be normal. There is no normal.
I love that normal thing.
Isn't
I
it?
love that normal
Well,
thing, as though there's some perfect normal out there.
Right, right. Well, I tell all of my patients, everybody's eating struggle is unique as a fingerprint. And what worked for your sister may not work for you. And by the way, what worked for you 10 years ago may not work for you now.
there's a brilliant point, right? Our bodies change, whether we're male, female, doesn't matter what. Our bodies change in a very predictable and natural way. And for lots of reasons, including our perception of society's norms, we decide that we want to fight those changes instead of embracing the gift of aging.
Right.
Yeah.
Right.
A gift that is not everyone is privileged to
Mhm.
have.
You bet. You bet.
But I have to tell you,
Absolutely.
you know, Jenny, to your point, the messages are about be thin or be thinner are so ubiquitous. I have to give you a funny example. I was in the Caribbean last month in a beautiful hotel. I walk into the bathroom. What's there? A scale.
Oh God.
I'm on vacation.
Oh God.
What the hell is a scale doing there? But here's the funnier, worse part. The company that manufactured the scale was called Thinner.
I guess we have to ask the hotel to put Clear Step into their bathrooms, but okay, that's another story. I said I guess we have to ask the hotels to use Clear Step. Clear Step is one of several where you can step on a pad and the practitioners that you're working with get to see your weight, but you don't in case that's a trigger for you. So anyway.
And I'm going to take this opportunity just to do a PSA since we're talking about scales. I always feel like I need to drop it in. A reminder that you can go to the doctor. I just did this week. And she said, so we're going to just, hop on the scale and then we'll measure how tall you are. I was like, I never weigh myself. She was like, okay, and moved on.
Wow.
You can always say no. You can always say,
I don't weigh.
no, I don't choose to be weighed today.
It's very interesting that you say this because 10 years ago, that was not the case. 10 years ago, you had to do battle with swords with the poor medical assistant who said, if I don't weigh you, the doctor's going to be mad. I think they at least figured out this is a battle not worth taking on anymore because there are more and more people saying, why do you need that? That's not a vital. My blood pressure is vital. My weight is not vital. So I'm so glad you brought that up.
But you do need a few good zingers, right? One of those is what you just said. My weight is not a vital metric. Another one is If you weigh me, it will do me harm.
Mhm.
Oh,
It will trigger my issues, and you
wait,
don't want that to happen.
that would take
Really,
a
like, you
lot of
need to come a little bit
bravery.
armed.
That would take a lot of bravery for someone to say.
Yes.
Yes.
Yes, for sure.
And of
And you
course,
can just
we've
start
all
with a
had
no.
patients who live in larger bodies who've gone to the doctor for a sore throat, a broken toe, and the doctor says, you need to lose some weight.
I'm so admiring of the idea that you wrote the book, codified this, took a stab at what's a very huge and new issue for so many people. What is one of the biggest take homes other than please get guardrails, please get medical support, please don't do this on your own? What's one of the takeaways you would really love people to have from the book?
Thinness does not define your happiness. You think it does until you get there. That's what, the Hildebruch expression of thin fat. She said, and I love this, she said, people who assume that becoming fat is going to take care of their discomfort, their dissatisfaction in life, find out that weight loss has not done for them what they hoped it would.
Right.
So I think communicating that weight loss is just about weight loss, which can be important. And I want to tell you another case, but it will not solve all your life problems. Like this girl said, I know I have to deal with the sexual abuse. I'm sure a lot of our patients say that. And she knew she wasn't ready.
I think one of the basic tenets that we, base our podcast on is the idea that weight actually doesn't matter at all. Meaning, it's how you house this body, this miraculous body that you have that has hopefully served you well, that has done so much with you and for you, and sometimes doesn't do things the way you would like it to. But the
Right.
more you fight it, the more you're at battle. And there's enough battles out there to fight without fighting with yourself. And I think it's so important to acknowledge that, yes, people are going to do what they do. They have the right to choose what they want to choose. But for some, this is really at great sacrifice. And so, a financial sacrifice. And so now they're going to over the counter versions or, compounded versions,
Right.
which have no scrutiny right now, no classification, nothing. There's nothing that's guiding them. And I think if people are going to do this at all, they must do it through their physician and through the direct pharmaceutical, at least do it that way. I mean, would you agree?
100%. And also to recognize, do you remember like 100 years ago, Judy Hollis came out with this book, Fat as a Family Affair?
I sure do.
Mm-hmm.
I thought it was a great title. So what I'm learning is Ozempic or GLP-1s is a family affair.
Oh, I'm seeing it.
And
I am seeing that.
how does it come out for you? What have you observed?
Well, I'm just seeing like, oh, well, my mother went on Ozempic, so I should too. It worked for my sister. I'll do it too. Right? As though, and I want to go back to what you said, Mary Anne, as though everybody's journey around food and body is the same when it isn't. But what you said, I think is so beautiful that each person's body story and experience of food is their own fingerprint. And how do we center someone's own story versus here's this external expert or this external drug, and this is going to tell your story just like it did in either the studies or in your family of origin or the family that your immediate family. It's like, no.
You bring out the point, which I think needs to be said out loud. These treatments need to be individualized. They have to be the right person who can benefit in the right dose with the right support. But a colleague was talking to me about a situation she encountered, and this speaks to Ozempic is a family affair. She told me about a girl who is in very rigorous treatment for anorexia.
Sure.
While her father
Yeah.
is on GLP-1s
Yeah.
that are prominently displayed in the refrigerator.
Yeah.
I'll see you and I'll raise you. I have clients that are being actively treated for various forms of disordered eating, and their parents, who are making their own choices about these things, are both on GLP-1s, and either they're prominently displayed in the refrigerator, and that's a whole discussion, or they're keeping it as a big
They're
fat secret
hiding it.
and putting it in some secret refrigerator, somewhere else in the house.
Underneath the zucchini.
Right, and so it's really it's a
My heart is
it's
breaking.
uncharted territory here, right? Because
Yeah.
first of all, we don't want family secrets. That's never gonna work out well. Number 2, we want consistency of message, right? And imagine, a 16-year-old who says, "You're kidding, right? I've been in treatment for 2 years. I've been at different levels of care. You've been supporting me. You've been helping me through it. And now you want to lose weight." "Well, yes," says mom. You are 16. I'm in perimenopause or I'm in menopause. Wait till you get here. I don't like what's happening to my body. "But mom, I don't understand. I thought the message was it doesn't matter what I look like." There it is.
Right.
It's a lively
That was
discussion.
destroyed in 1 nanosecond.
Right.
Right, but it doesn't only happen within a family system, right? I'm hearing it a lot from women with their friend circle,
Mm.
right? The impact, well, everybody else is the incredible shrinking woman. What about me? I should be doing that too. And it takes a lot of inner strength for someone to come back to their own body, their own sense of embodiment and what works for them. And it does. It's so countercultural to say, this is my body and I'm going to claim it and I'm going to live in my body in the way that I want to.
That takes so much courage. I want to tell you, I'm supervising someone who works in a community, I'm not going to name the community, where normal weight women are getting the medication. I don't know where they're getting it from. And normal weight 12th graders, normal weight,
Whatever normal is.
they were overweight and age, 17,
Right.
but normal weight kids are getting these medications. It has to be through parent support. Someone has to pay for this. And she said the whole community used to want to be thin. Now they want to be thinnest. And I've worked a lot in that community. I've written a column in their magazine for 20 years on declaring peace with emotional eating. But it's a microcosm of our culture, our world.
And without naming that community, let me also say that intergenerational trauma plays a huge role. Intergenerational, it cannot be overstated. And dare I say, without stepping into a big puddle here, that a lot of the political events that are happening in our world right now are re-triggering all of the intergenerational trauma that has preceded it for decades. And so this is something that we have to be very mindful of because, you used a phrase that, so many people use, normal weight. It's a term we all use, right? But there's actually no such thing. I think what we're trying to say is there a size that someone can be in their own body and just feel like, you know what, this is my body. And by the way, if I look to the left of me and I look to the right of me, are other people sort of looking the way I look? Well, that's just called being part of a society. But when it drives your every thought and when it drives your every action, and when you are afraid that you're going to pass on those thoughts and actions to your own children, that's when we're seeing folks. That's when they're coming to all three of us to say, uh-oh, wait a second, this has to stop somewhere.
You're talking about, intergenerational trauma. And I think we need to add in, when we talk about what we're talking about is legacy burdens, right? The intergenerational trauma, the burden that's happened before us. But we now have to add in food and body and this desire for thin, as you say, Mary Anne, thin and thinner, right? And adding that to the intergenerational trauma, not just, we survived or we were fleeing a country or we were in scarcity as a line of families, But we have to add in now, wow, my family has been impacted by this pressure to be small, to belong, to assimilate.
Assimilate.
And in order to do that, I have to be tiny.
Right.
What happens when we shrink ourselves? Like, this gets into a much bigger conversation about how much space do we take up? How much voice do we have? How much presence do we have? How much influence do we have?
I'll also say where diet culture is concerned, you can't win, because there's a whole world of people that says you should be thinner. Now there's a whole world that says, oh, you lost weight, but you cheated. You did it through the
Yeah.
through the injections. You didn't really do it. There's just, there's
We
no
can never get it
go
right.
into it. Yeah.
No,
We can never
exactly. You can never get it right.
There is a documentary that the New York Times did called The Weight of the World.
Mhm.
It's on
PBS?
Channel 13.
Mhm.
PBS, yep.
Yeah. It was following the journey of 4 different people. One of them caught my attention because I had never heard anyone express the pain of being fat all his life, with the history of bullying. He was over 300 pounds, or closer to 400 most of his life. I've never seen anyone express the pain and the relief that now he's been on Zepbound for 2 years. I was so moved by his complex emotions that I reached out to him and I interviewed him. And part of his grieving was, this wasn't available to me earlier in my life. And I think often how much it could have made a difference if I had been in a more normal body.
In a smaller body.
In a smaller.
I want to name one thing here. I hear that and I hear his pain, and it's because of the society he lives in, and he was bullied, and that's a traumatic and awful thing. And if he's happier in the body size that he's in right now, power to him. But I have to name here that just a slight pushback, which is there are people that walk around in larger bodies and are quite happy. They are exactly who they are. They try to just, do all the things in their life that they want to do, including body movement, including being active, and including everything that's included in life. And they happen to be in a larger body. And, if it were not for bullying, if it were not for societal norms, if it were not for diet culture, people could really just exist in whatever bodies they were in and not be worried that the entire world was judging them.
Maybe. This man never had sex in his life until he lost weight.
Because he internalized, I don't know the poor gentleman, right? But he
was so
internalized.
uncomfortable. I see, I agree with you, but I have a part of me that also disagrees. People are uncomfortable. They can't fit into airplanes. They can't fit into airplane seats, which is not going away anytime soon. People are uncomfortable.
And so we ask them to adjust their bodies instead of making airplane seats that are actually a more accommodating size. That's my only point.
Right. And as you just said, more power to them if we can get the airlines to agree.
Right.
But I do think that there are people, that people are on a continuum. There are people in larger bodies who, as you described, go merrily along their way and they do everything and feel like they're part of their family and they work out. And people are on a continuum. And I think those who feel very miserable about being in larger bodies do have this now as a tool. And it has to be talked about as a tool because it's not the end all and the be all answer, but it is a tool.
I think that's an important final point to make, right? That it is not the be all end all. It is a tool in a very large toolkit. And sometimes that toolkit's going to include a lot of different things,
Yeah,
including food. Yeah.
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 And Mary Anne, just to wrap up, is for someone who's listening and they're struggling with their relationship with food, and they might identify as being an emotional eater, what's a final message you want to give to them?
A poem. I'm going to read a 4-line poem. It's written by the American poet Nayyirah Waheed, and this is the poem. And I said to my body softly, I want to be your friend. My body took a long breath and replied, I've been waiting for this my whole life.
Mm.
I cannot read that poem without wanting to cry.
Very moving. Very moving indeed.
It is. It's exquisite. Mary Anne, thank you so much for such a robust and juicy conversation. We appreciate your time and all the work you've done through your whole career and your dedication to helping people feel like they are friends with
Right.
their bodies.
So let me just introduce you. I'd like to send both of you a
Oh,
copy.
that's very kind. Thanks. Ozempic
That's
for
very
Smarties.
kind.
Like a
Thank
therapist
you.
tells the straight skinny. Okay.
Yeah.
Thank you again,
Great.
Mary Anne.
Let me send you each a copy, and
Thank you. It's very kind.
it captures, I think, a lot of nuance, which is what I think this discussion is all about. And I appreciate your having me.
Our pleasure.
And we could talk more about this at some point.
We'd love it.
Absolutely. Thank you so much. Bye-bye.